Hello everyone. Today I'll be briefly describing about space maintainers, the very basics of space maintainers. Okay. So by definition, space maintainer is an appliance which is given to maintain the space which is lost prematurely. Okay, or we can say it's an appliance which maintains the mesiodistal width of the lost primary tooth or teeth and thereby restoring function to a certain extent. Okay, these are always passive and they do not apply any force on the teeth. The main objectives are preservation of primate and leeway space, preservation of the integrity of the dental arches, preservation of normal occlusal planes, and in cases of anterior space maintainers, they should aid in aesthetics and phonetics. Okay. Then there are certain factors which are to be considered. Okay, so one of the most important factor is the time elapsed since tooth loss. Okay, it is advised to place the space maintainer as quickly as the primary tooth is removed. Studies have shown that the maximum space loss which takes place is within the first 6 months after removal of the or premature loss of the primary tooth. Okay, then second factor is the dental age of the patient. We should always consider the dental age rather than the chronological age because of the variation in the eruption of teeth which is generally observed. Then the third factor is the amount of bone which is covering the unerupted tooth. Okay, the more the bone is covering the unerupted tooth, the more time it will take to erupt. Okay, normally the premolars they take 4 to 5 months to erupt through a bone level of around 1 mm. Okay, then the sequence of tooth eruption, adequate consideration is given to the adjacent developing and erupting teeth. Okay, there is mesial migration of the teeth which are adjacent to it, which are posterior to the lost tooth, usually which is seen. Okay, so which causes space closure. So all those things should be considered. Then in certain cases there is delayed eruption of permanent teeth, so the space maintainer has to be kept for a longer duration. Then congenital absence of permanent tooth, sometimes space closure is required, but there are times when we need to retain that space for the replacement in future. Okay, then the ideal requirements of a space maintainer should maintain the mesiodistal dimension of the tooth. It should not interfere with the eruption of the adjacent teeth or the permanent teeth. It should be functional so as to prevent supra-eruption of opposing tooth. It should be as simple and as strong as possible. It should maintain the individual functional movement of the teeth. It should be easily adjustable. Okay, it should not endanger on the remaining teeth by imposing excessive forces on them, and should not restrict normal growth and developmental processes, and should not interfere with mastication, speech and deglutition, that is normal functions. And it must be the patient must be easily able to clean it easily, can be cleaned easily. It should not serve as a trap for food debris because that would lead to caries development. And it should be durable and corrosion resistant, should be reasonable in cost, and should have universal application. Okay, so the indications are if the space after premature loss of deciduous teeth shows signs of closing. When a malocclusion exists, that would be further compounded with loss of space. Or if this use of space maintainer will aid in or make the future orthodontic treatment less involved. Okay, or delayed eruption of permanent tooth, or if there is congenital absence of permanent tooth where we need to maintain that space for further replacement in future. Okay, then there are certain contraindications when there is no alveolar bone overlying the crown of erupting tooth and there is sufficient space for its eruption. Because there is no overlying bone, the tooth is anyhow going to erupt soon. Okay, when space left is excess of the mesiodistal dimension which is required for the eruption of the permanent tooth, and space loss is not expected at all. Okay, or if the radiograph of the extraction site shows that 1/3 of the root of succedaneous tooth or the permanent tooth is calcified already, that means the permanent tooth is going to erupt now. Okay, if the space shows no signs of closing, or when there is a gross space discrepancy which is anyhow going to require future extractions and orthodontic treatment which is comprehensive, then in such cases also it is contraindicated. And when permanent succedaneous tooth is congenitally absent and space closure is desired rather than retaining of the space, then also it is contraindicated. Okay. Then comes a classification according to Hitchcock. It can be classified as removable, fixed or semi-fixed, functional or non-functional depending on whether we are going to involve placement of teeth or Pontic, unilateral or bilateral. It can be active or passive, but usually by definition space maintainers are passive. Okay, they do not apply any forces on the teeth, with bands, without bands, and combination of any of the above. Then another classification says can be removable, can be complete arch, or it can be individual too. Then according to Hendrickson, it can be fixed or removable, class 1, class 2, non-functional, does not serve the function, band and loop, bar and loop, functional, or class 2 is cantilever type, which is distal shoe or reverse band and loop. So these are, and acrylic partial dentures, which includes Pontic or the teeth and thus become functional. Okay, so there are some steps which need to be taken. Okay, so the essential steps which are required in fabrication or for space maintainer, making of the space maintainer. First of all, take a proper history and examination of the patient, collect all the diagnostic data, the radiographs and everything, collect and analyze the tooth development, analyze the tooth size, analyze the space. Space analysis is very important. Okay, that's a separate vast topic altogether. And then prediction of growth and future occlusal relationships. The removable space maintainers, they help in mastication, speech, aesthetics, and to prevent space closure. The types are acrylic partial denture, complete denture, and there can be removable distal shoe space maintainer, which is a modification of distal shoe Starkey's appliance. Indications when all the teeth are lost, like in rampant caries or patients who have ectodermal dysplasia or any other deformity like that. Bilateral loss of posterior teeth and mandibular arch before the eruption of permanent incisors, and missing anterior teeth where it is made functional. Then bilateral loss of multiple primary posterior teeth before the eruption of first permanent molar, and when space maintenance is required for a very short period of time. So these are all the indications of removable space maintainers. So these are some pictures which are showing here. You can see these molars are missing and this molar is missing over here. So removable partial denture like space maintainer has been given here also. And this is a complete denture which has been given, and it is indicated in patients who do not have any of the primary teeth, like in cases of ectodermal dysplasia. Okay, but only disadvantage is that parent and patient cooperation is required to wear it. Then breakage and loss are, uh, seen most of the times, which lead to high failure rate. Okay, so the advantages are they are easy to clean, they permit oral hygiene maintenance, and can be worn part-time, allowing the circulation of blood to the soft tissue. They serve as a device which is functional, help in mastication, phonetics, and aesthetics. Dental checkups can be done for caries. You can remove it easily and see if there is any demineralization or any signs of dental caries, initial dental caries. Dental checkup for caries detection is possible. Then room for permanent teeth can be made without changing the appliance, and by modifying it a bit. Stimulate eruption of permanent teeth. It helps in development of tongue thrust, helps prevent development of tongue thrust habit in extraction space. Okay, then disadvantage is that it may be lost or broken. It is not effective in patients who are uncooperative and do not wear it. Then lateral jaw growth may be restricted if clasps are incorporated. It can cause irritation of the underlying tissues. It is contraindicated in patients who have allergy to acrylic. It cannot be used in epileptic patients who have uncontrolled seizures and uncooperative patients. Okay. Then comes fixed space maintainers. There are so many fixed space maintainers like band and loop, crown and loop, lingual arch, palatal arch appliances, Nance palatal arch, transpalatal arch, distal shoe maintainer, then aesthetic anterior space maintainer, band and bar type. All these are the examples of fixed space maintainers. Okay, so there are certain advantages and disadvantages. Advantages are that bands and crowns are used which require minimum or no tooth preparation at all, and they do not interfere with passive eruption of the abutment teeth. Jaw growth is also not hampered. Succedaneous tooth free to erupt. It can be used in uncooperative patients, and masticatory function is restored if Pontic is placed. Okay, disadvantages are that we need elaborate instrumentation with expert skills for fabrication of such appliances, and it may result in decalcification of tooth material which is there under the bands. Okay, then supra-eruption of the opposing teeth can take place if Pontics are not included, and if Pontics are used, it can interfere with the vertical eruption of abutment tooth and may prevent eruption of the permanent tooth. Okay, if patient fails to report back. Okay, so let's first see what is band and loop space maintainer. Band and loop space maintainer is a unilateral, fixed, non-functional, passive with bands. Unilateral because only one side we are using it. It is fixed type, patient does not need to remove it. It is non-functional because we are not including a Pontic or a tooth, and it is passive, it's not applying any forces, and it is with a band. Okay. Indications: premature loss of a primary first molar or premature loss of second primary molar after eruption of the first permanent molar, bilateral loss of single primary molars before eruption of permanent incisors, because after eruption of permanent incisors we can give a lingual holding arch. Okay, so before the permanent incisors have erupted we have to give band and loop space maintainer, and in cases of premature loss of primary canines also it can be given. Contraindications are an occlusion which is extremely crowded or already exhibits marked space loss, or high dental caries activity, because then beneath the band decalcification will happen and it will worsen the situation. Replacement of primary second molars in primary dentition without partial clinical eruption of 6, that is permanent first molar. Okay, and cases that need guidance of eruption or sequential extraction of primary teeth without removal of permanent teeth. Okay, in such cases also it is contraindicated. Advantages: it is very economical, it requires less chairside time, it allows transverse growth of the jaws. Disadvantages are that it is non-functional, it does not restore the function, it does not prevent supra-eruption of opposing permanent teeth, it can lead to slight mesial tipping if the loop slides below the contact area. Then there are certain steps in the construction of band and loop space maintainer. I am not going into the detail of it, just the steps I have mentioned. So first we have to fabricate the band by band pinching, then take an impression, then place the band in the impression and stabilize it. Then we cast a stone model out of it and then adapt a wire loop, and then we solder the loop to the band. Okay, and then later smoothen it, polish it, and then we try it in the patient, and then final cementation of the band is done or the appliance is done. Okay, so these are the pictures. Here we can see if this is indicated for extraction, then this is how this permanent first molar is banded, and then this band and loop space maintainer is given, and then we can see once the tooth erupts we can remove the appliance. Okay, so this is band and loop space maintainer. There are certain modifications of it like crown and loop, where instead of a band we use a crown. Okay, and band and bar, where instead of the loop there is a bar, a straight bar of a wire is used. Reverse band and loop appliance, in which the band is placed on the tooth which is anterior to the lost space. Okay, and loop only on one side like this is called mayonnaise appliance. Okay, so all these are the modifications. Crown and loop looks like this. There is a crown and loop. Okay, crown and loop. It's usually given when the tooth, which is abutment tooth, is pulpectomized or does not have a sound tooth structure. Okay, indications. Most of the indications of band and loop space maintainer also apply to crown and loop. Crown is used in preference to band in if the abutment tooth is highly carious, exhibits marked hyperplasia, or if it is pulpotomized or pulpectomized. Okay, then comes another appliance which is distal shoe appliance. It's also called as eruption guiding appliance because it guides the eruption of the first permanent molar. It's also called as Willett's appliance after the name of its uh, the person who invented it. Intragingival appliance, Roche's appliance, or Starkey's appliance, which is a modification of it. Okay, so this is how it looks. Can be given with a band or a crown. So this is before the eruption of the first permanent molar when the primary second molar is indicated for extraction. Then we put a band or a crown over the primary first molar and give a distal shoe appliance. Okay. Indications. It's indicated when there is premature loss of second decidus molar before the eruption of first permanent molar. When both the first and second primary molars are missing in the same quadrant, then distal shoe which is removable is preferred. Okay, that is Starkey's appliance. Contraindications. If several teeth are missing in the same quadrant as there is lack of adequate abutment. Okay, so because for distal shoe we need a proper abutment. And in medically compromised patients like patients who have blood dyscrasias or congenital heart defects, previous history of rheumatic fever, diabetes, generalized debilitation, immunosuppressed patients, because in such patients, since this is an invasive procedure, it is difficult to do it, and also it involves certain other risks. Also patients in poor oral hygiene and lack of patient or parental cooperation, also it cannot be given. Disadvantages are that a small metallic tattoo may form at the space where the vertical component enters the gingiva, and the controversy exists that the healing at the site of invagination of the vertical component, that it does not take place as it should be. In patients who are medically compromised, there are certain other alternatives like use of pressure appliances or to allow the first permanent molar to erupt with a mesial tilt, and then later we can regain the space which is lost with the help of space regainers. Okay. Then comes another appliance which is passive lingual arch. You can see this is a bilateral appliance which is fixed. It has bands and non-functional because we are not involving any pontic over here. Passive space maintainer. Okay, so this is how a lingual arch looks like. Okay, this is a lingual arch with spurs. Indications. Maintenance of arch perimeter, not just quadrant perimeter because of premature loss of the primary teeth. Retention or stabilization of the position of mandibular anterior teeth after tooth movement to prevent the relapse in mandibular anterior crowding and changes in the bite depth. There are contraindications like anything that requires frequent adjustment, okay, tooth movement or space regaining. Then rampant dental caries with high plaque scores in patients where anterior or posterior crossbite if mandibular teeth are contributing factors, and extreme mandibular anterior crowding or lingually erupting succedaneous teeth, because we need to adapt it to the incisors. Okay. So here you can see this is how it looks like, band on the molars and then bilateral loss of the primary molars, and this is the arch. Okay, so advantages are it is economical as compared to if we give two bilaterally two spare band and loop space maintainers. It is an excellent source of anchorage because it incorporates resistance of several teeth. It allows free. So it is an excellent source of anchorage because it incorporates resistance of several teeth. It allows free individual movement of teeth while maintaining space in the desired areas. It causes little or no inconvenience to the patient. It is less bulky than removable acrylic space maintainer. It is less conspicuous also, and it serves as a space maintainer for more than one succedaneous teeth in the arch. The disadvantages are that the child may disfigure the wire in an attempt to remove any entrapped food debris with finger. Okay, it's more prone to breakage and loss, and prolonged use of orthodontic bands on the tooth may facilitate decalcification of the teeth which are banded, and the arch wire may become embedded into the soft tissue. This may occur if patient is not maintaining the oral hygiene properly. Okay, modifications are it can be made with a semi-fixed by welding a molar tube on each of the bands on the lingual aspect. Okay, so if we weld a molar tube, then it can be made semi-fixed. Okay, the arch wire is passed into the tube instead of soldering to the band. So part of the design is fixed, that is the bands are fixed, and the other part, which is the arch wire, is removable. Okay, so it becomes a semi-fixed appliance. Then a U-loop can be incorporated in the arch wire to make it active, okay, which aids in distalization of molars and proclination of collapsed incisors. So there it acts as a space regainer. Okay, then spurs can be added on the arch wire at the distal end of the canine to prevent the distal collapse of the canine. Like this, spurs can be added. And also when only centrals have erupted and laterals have not erupted, then it is modified to allow the eruption of laterals like this. So we are taking only adapting it to the centrals. Okay, in this picture we can see. Then transpalatal arch, it is also a bilateral appliance, fixed, non-functional and passive. The appliance is designed to prevent the molars from rotating around the palatal root of molars, which are lost bilaterally. Okay, this is how it looks like. Simple appliance indicated when one side of the arch is intact and several primary teeth on the other side are missing. And advantages are no inflammatory changes can be seen because we are not using any acrylic plate. It is more effective if there is bilateral premature loss of deciduous first molars. And disadvantages that some patients they report entrapment of food debris. Okay, bonded type space maintainer is the one which where we are not using any bands. It's ideally indicated when deciduous tooth in the posterior segment is prematurely lost. Advantages that band adaptation is not required, lab procedure is also not required, less chair side time, it is more economical, takes less time. Okay, disadvantages that there are lack of clinical studies, which tell that such kind of space maintainer should be used frequently. Then Nance appliance, it's a bilateral fixed non-functional passive appliance, looks like this. Here there is an acrylic button which comes in the anterior portion of the hard palate. Okay, so indications when bilateral primary molars are missing in the upper arch, then Nance palatal arch is given. Okay, this is how it looks like. Both the sides primary molars are missing, and this is how we incorporate acrylic portion in the anterior part of the hard palate. Okay. Advantages, it is economical as compared to band and loop space maintainer being placed if there is bilateral loss of primary molars. It allows the growth transversely in the intercanine areas. If deciduous second molars are used as abutment, it allows the transverse growth in the intermolar area as well. And disadvantages that it requires more clinical skills and dexterity. The palatal button may cause food accumulation and inflammation of the soft tissue in that area. And if permanent molars are used as abutments, then it does not allow any intermolar transverse growth. Modifications by incorporating teeth into it to replace the missing anterior teeth. Okay, it can be made active by incorporating U-loops into the wire. Opening the U-loop can cause distalization of the permanent first molar. It can be used as a reminder appliance for habit breaking also by incorporating spikes or in the acrylic button like this. Okay, and also if we are incorporating teeth, that helps in better aesthetics. So coming to the conclusion, while a space maintainer may not always be used, space maintainer we are using to maintain the space for the eruption of the permanent teeth and prevent their mesial migration when primary teeth are lost prematurely because of caries or trauma. Okay, so while a space maintainer may not be always used, but it's always a good practice to be aware of the types which are available so that the right one can be chosen if such an appliance is to be considered. Okay, so for unilateral loss, Just to summarize, band and loop, crown and loop, band and bar, removable functional appliances. For bilateral loss in maxilla, transpalatal holding arch, bilaterally placed band and loop can be given, or transpalatal arch, removable functional appliances. For mandible, lingual arch after the eruption of permanent incisors, bilaterally placed band and loop before the eruption of the permanent incisors, and removable functional appliances can be given. Okay, so this was all about the basics of space maintainers. If you people have any doubts, please do let me know. Thank you so much for listening.